Okay, thank you so much, Lisa. I think I will never forget Lisa Simpson equating a song written and sung by the police to big data in the healthcare system, right? That's embedded in my brain forever. Thank you for having me, and thank you for this opportunity to talk a little bit about how AHRQ has been really fundamental for my research agenda. So what I thought I would do is just talk about a couple studies that I've done over time and the role of AHRQ in kind of encouraging or developing those studies. So when I was an assistant professor, I was very fortunate to receive a training grant from AHRQ for my early work, and that work was, or at least the work in the training grant was focused on health plan choice. So I had done some work as a graduate student thinking about employers and how do employers decide which plans to offer to their workers and what are the implications of that. And I was really interested in developing a kind of a broader agenda around health plan choice more generally. At that time, health plan choice was very important in the context of Medicare Advantage, right? People were choosing between the Medicare system, regular Medicare, and among the different types of Medicare Advantage plans available in their market. Since then, health plan choice has obviously become more important when we think about the development of Medicare Part D, where folks choose among private plans for their prescription drugs, and of course the Affordable Care Act with the exchanges, where health plan choice is also very important. So I did work, so I did receive this early career training grant from AHRQ to work on this. And from my perspective then, as well as my perspective as a more senior faculty now, I think I wanted to highlight some of the really crucial pieces or the crucial outcomes of that early career support for investigators. So the one that people talk about all the time is just to give early career investigators time to really develop their research agendas, like protected time to think very hard about the problems that they're interested in and think creatively. It's like, you know, if you think about an assistant professor, you can roughly equate that period of your career to your 2-year-old, right? So you think about your 2-year-old and they're learning so many things and their brains are firing and, you know, they're making progress every day. Being an assistant professor as an academic is kind of equivalent to that period. Those things that you focus on and those things that you work on are really fundamental for the development of your future career. So protected time is important. I think the other things that are maybe less focused on that are also crucial about early career funding is it really makes you sit down and lay out your research agenda, right? So you're all excited, you come out of your PhD, yay, you know, we're ready to go. But you have to think very carefully about what you're proposing because it has to go through the reviewers. You have to tell senior faculties at your institution what you're working on, and that is very important as well. And then the final thing that I think is can be underemphasized is it creates this mechanism for people to identify and develop relationships with mentors, right? So these career awards require you to identify mentors. You have to go talk to them. You have to get their buy-in for their project. Just that process of identifying them makes you think about where you're going, what you need to get there, whose help you need, and then the formality of writing down those relationships and submitting them to a funding agency can really cement those relationships. So for those reasons, it's very important. So when I was working on my project, I was very focused on health plan choice, and I was really interested in this idea of, well, there are these different types of plans out in the market, right? There are, very tightly managed HMOs, right? So those have very low cost sharing, and there's kind of some centralized administrative structure from the top. And then there are these other plans out there that rely more on patient cost sharing to control healthcare use. And those seem like very different types of products, right? And how do people choose among those products, and how do we convey information on those products? And are we sure we're creating the right incentives for people to choose correctly? So I was walking around thinking about this, and I walked over to the economics department at Stanford, and I ran it across this idea, these things I was thinking about, across a very a star economist at Stanford named John Levin, who has since then gone on to win the John Bates Clark Medal. And John thought my problem was interesting, right? So I was very excited about that, and we ended up working on this project with this small data set to think about these questions. He brought in a graduate student from the economics department named Neil Mahoney. Neil is now a faculty member at the University of Chicago, working almost all his work is on health insurance and healthcare issues. So I feel like the opportunity to have the freedom to go around and talk to folks about this project was really instrumental in getting both John and Neil involved in this research. So we did a lot of interesting work. We thought about, well, we want to think about the risk of the people enrolling in these types of plans. We want to think about people's preferences, who would like, different styles of care. And we also want to think about the cost, right? And I'll just talk about a couple things that we found in that study. So one thing that we noticed is when we really looked carefully at the data, we focused on a setting where people were choosing among these two different types of plans. We noticed when we looked at the cost that HMOs had a cost advantage. They were cheaper, they were providing care, we think, more efficiently, but that cost advantage was really concentrated on people who were sick, people who had relatively more chronic conditions, than other folks, and that's where the HMOs were really kind of delivering their bang for their buck. On the flip side, when we looked at the contribution policies that employers were setting, we found that the way employers were setting contribution policies, not through their own incentives, but more through regulation, were not kind of steering people to the right plans. Like, we weren't creating strong incentives for the sickest among us to enroll in the types of plans that will really kind of manage their care effectively, right? So that was, and I still think that that's an important issue in thinking about the healthcare system and trying to create informed choices among consumers so they can really understand and have the right incentives to choose among different types of plans. Okay, so that was an example, I think, of the the opportunities that early funding or early career funding created in my case, and in the ability to bring in other folks who were interested in this area to work on them. I wanted to talk just a little bit about two more projects. One is a project that is just kind of wrapping up and was funded through PCORI. There was a lot of research that looked at academics really just love to point out where people are making bad decisions. We're like, oh, you should have chosen that plan. Why did you choose that one? You chose a dominated plan. It looks like it wasn't as good as the other plan. And I got a little bit tired of that research, right? By basically saying that people were making bad choices. And I wanted to work on a project to actually help people make better choices. So with funding through PCORI, we did kind of a full spectrum analysis of, well, we focused on Medicare Part D, where there was lots of research that people were maybe not making optimal decisions in this context. So we started from talking to patients, talking to consumers, talking to pharmacists, trying to figure out where the problem points were, developing a tool in conjunction with our stakeholders to help people choose among plans, and then rolling that plan out in a randomized controlled trial. So that, and in that case, when we really developed the tool with the patients in mind, we found that our tool was actually pretty successful. We were able to move people across different plans, move them into plans that covered their drugs more effectively, and helping people make better choices. Okay, I'm going to quickly talk about one more area of research that we're working on. This is funded by an R01 from AHRQ, and in this project it's a little bit different, but we're focusing on these incredible changes that we're seeing in the organization of the delivery of healthcare, right? So if we think about physicians are increasingly working in large groups. Sometimes they're multi-specialty groups, sometimes they're single specialty groups, and those groups are increasingly affiliated with hospitals. So we're using data that covers almost all of the US, trying to characterizing those groups and looking at the impact of those, the organization of different delivery systems across markets and how it affects care. I want to highlight this work because it's really, AHRQ is really one of the only homes for this type of work, right? So AHRQ goes across disease types. You can think about cost and value, as Lisa talked about, and those concepts are crucial for our research. And what we're doing now is really trying to think about how the organization of healthcare delivery affects cost and value in the healthcare system. Okay, thank you. Thank you.